Okay, guys, so we are going to move into another section. We're going to talk about person-centered assessment and care planning. And Veronica and Kimberly are bringing around some paper for an activity, but just to give you a heads up about, like the next hour and 10 minutes, we're going to be talking about person-centered care, about assessment and care planning. We're going to be talking about best practices in care planning and then some common challenges that people face and some possible solutions. So, yeah.
For 1 second. So everyone has the slides. And I know there were a couple of people in the front row before who felt like they were going to not leave here with their neck intact. So we want to be respectful if you're not feeling the first row because you feel like you can't see. You do actually have the slides. Or feel free, to maneuver around. I would just ask that nobody go like way in the back. Just kind of, keep us in the front of the room. Sorry, Carla.
Sure. Yeah, we don't want anyone to, anyone's back to go out, neck to go out. we want to support you. So let us know if you're really having trouble in the front row. Okay, great. So before we go through our care planning section, I know what I was going to do. And before we get to our activity, so how many people in this room, as part of their care coordinator work, do care planning? Okay, so maybe half. And how many do comprehensive assessments of their patients or clients? Okay, similar. All right, great. So here's what you're going to do. On your blank piece of paper, I have one more question for you. How many in here work primarily with older or geriatric population? A lot. Okay, great. So for this activity, what I'd like you to do is take your blank piece of paper and fold it in half. And then I'd like you to think about if you work with an older population or, if you work with an older population, and if you don't work with an older population, you can substitute someone else you work with. I'd like you to think about someone who you might categorize as difficult, or maybe someone else in your organization might categorize them as difficult. And I'd like you to just jot down on one side of your paper what you think the notes in the medical record might look like to describe this person, right? So how it would be documented in the chart or in the EMR, maybe that's their diagnosis, maybe that's some behavior they're doing or not doing, you know. And if you don't work with an older person, then you can think of somebody else who, again, would be classified as a difficult patient or client. So take a couple minutes to do that. So the next thing you're going to do is write on the other side of the paper how you think this person's family or close friends might describe this same person. Yeah. Someone who knows them. The last thing you're going to do is open up your paper, and on the inside, you're going to write how this person would describe themselves. And it may help you to think about what that person's, we call it self-talk, like how they would talk to themselves or sort of explain their behavior to themselves. How would they describe themselves? Somebody want to share out? Yeah, great. Maggie?
I was thinking of an older person and
just tell us in the chart what you put.
Yes.
Family, and then how they describe themselves.
Okay, in the chart, there might be words like confused, anxious, combative, declines, visits. The next one was...
The family or friends
family,
would describe this person.
Might say the person was forgetful, confused, anxious, stubborn.
Okay.
And the person might they might also say they were forgetful, but they would say they were independent and doing fine.
Okay, great. Somebody else want to share out?
So I put dementia with aggression, combative, unable to follow verbal cues or directions, unable to manage self-care, requires 24-hour supervision for safety.
Nice note. Read the family part.
Grandmother, mother, we love her. She used to have all holidays at her house. She's now suffering, looks like she's scared, in pain. We don't know how to help.
Okay, and then how the person would describe themselves.
I'm a mother of 4 children. I worked hard and raised my family at the same time. I can take care of myself. Why doesn't my family take me home? After all I sacrificed for them, why don't they want to care for me now?
Great, thank you. Somebody else want to share?
So in the chart, attention seeking, borderline, history of violence and self-harm, incarcerated for behavior, demanding and verbally abusive toward treatment providers. What their friends or family would say, giving, thoughtful, generous, a volunteer, recognition for their hard work and recovery, intense at times, and an artist and photographer. And what they would say about themselves, I need help and no one is helping me. People treat me differently because of who I am. I just want to be treated fairly. I love my family and want to share my life with them, and I am proud of myself for my work in recovery.
Thank you. Anyone else?
I have a note written as patient has copious complaints about a variety of issues of unknown etiology which appear to be psychogenic. As the, what's the next one?
The family or friends, how they would describe this person.
As never happy, difficult to please, always complaining. In the person's description of herself, I've had a difficult life. I've had to deal with a lot of trauma. I'm doing the best I can.
Sorry, so just so you guys could hear, the last one was, I've had a difficult life, I've had to deal with a lot of trauma, I'm coping the best that I can. Great, thank you. Okay, so what did you learn about this person that you did these 3 descriptions of, if anything?
The medical terms seem very narrow, a little hopeless, but very narrow and not, when you get into the other, it just makes it go a little bit in complexity.
Right, the medical terms seem narrow, and you said when you get into the other parts, right, we have a more complex understanding of the person. Exactly. Right, start to feel more empathy as you hear the other views, which kind of, you could see it in reverse. As we get into the medical language, perhaps we start to feel less empathy because of the language that we're using.
I guess in the hospital, it's just more descriptive, but once you go to the family and the person, it's more of a relationship.
Okay. Descriptive versus relationship, yeah.
Back to the time factor, I feel like, you know, if you have if someone takes a snapshot in the medical office, but as you have more interactions with people and longer interactions, then they have a bigger view.
Yeah.
And with that is, if I'm the patient and I know I only have this much time with the provider, I potentially have the kind of the drive to get what I need, and maybe that comes out differently. I mean, I see that when I meet with patients over time and over time, and we have established a relationship, and then building the bridge to the provider,
Right.
it changes.
Right, so time is a factor, right? How we behave in a short visit it affects the patient and the client, how they behave, and it affects how we behave, and it's different than having a longer period of time to get to know them. Yeah. Wait. Really? Hi, go ahead.
I think like pain is a good example because a lot of patients, when they come in and they're having a lot of pain, and to the provider maybe because pain is their main focus, kind of feel like, well, maybe they're drug seeking, and so, sometimes your note might say, patient, asking continuously for, so I feel like, so when you read the note, you automatically feel like maybe the person was just drug seeking, really wasn't having pain, and when you read these notes, you have, whereas you talk with the patient, so, well, I only had 15 minutes, I wanted him to know that I'm really having a lot of pain.
Right.
He didn't really care what was wrong with him, he just wanted to make sure if he had 15 minutes that he was going to get his pain addressed.
Right, right. So again, the visit distorts perhaps who that person is.
Absolutely.
And I think that's kind of what I'm getting at. And I guess I would ask you, how do we think the healthcare system diminishes or supports our sense of a person's health or their sense of their health? Not sure if I asked that completely clearly. So when you come into the healthcare system, what do we focus on, right? We focus on clinical conditions, diagnoses, symptoms, physical complaints, like we classify, right? But do we get a sense of the person necessarily in a 15-minute visit or we don't usually, right? And and we don't necessarily have language to even talk about those things. It's not necessarily appropriate to put into the EMR that the patient is a grandmother with 4 children who bakes chocolate chip cookies for them every Sunday morning, right? But that's part of who that person is, right? So what I'm getting at here is just for us to have an awareness of how the language we use in the healthcare system and our documentation and the visits and the time all kind of funnel patients into a certain way of us looking at them and understanding them, which actually is not particularly supportive for us getting at what their fuller sense of health is, right? I'll give you another example. Someone may have diabetes and we may be focused on getting their A1C down. But in fact, it's their back pain that really is the thing that's giving them problems and that they really want help with. But, we're over here focused on our lab results and, that diagnosis. Or what they need is help getting along with their family members, and that in turn will help with all the other issues. But we don't necessarily have that language or structure in the healthcare system, although perhaps in your roles as care coordinators we do. So we're going to take a short break, and then we're going to come back, and we're going to do our care planning and assessment section. Okay, we're going to get started. Okay, guys, so we're going to get started. So we're going to talk now about like I said, care planning and assessment. But first, I just want to hit on person-centered care. So not patient-centered care, person-centered care. So what do you think I mean by person-centered care? Yeah. Meeting. You speak up a little bit.
Sure, meeting the person where they're at, not just from a medical model, but also just sort of a life change. So meeting them all the aspects of their life to make sure that they're balanced.
Great. So Lisa said meeting the person where they're at, and not just from a medical perspective, but a life perspective, having a balanced approach. Yes. Other thoughts about what person-centered care is?
The person's own values and culture and things other than what's going on with them medically when you think about how to address their needs.
Great. Taking into consideration their values, the rest of their life, not just what's going on with them medically, to consider their needs. Very well put. Yes. Any other thoughts about person-centered care? Okay. So person-centered care is care that focuses on the whole person. And It's different from patient-centered care, and then it doesn't have a diagnosis or disease-specific focus, right? So you could be patient-centered, meaning trying to do things that are really more focused around the patient than the healthcare system, right? That's a good step forward. But still, patient-centered is a lot about being a patient, right? And we just did this activity where we talked about people are more than their diagnosis, they're more than their medical condition, and in fact, understanding that and approaching them in that way as a whole person with many, many selves other than the sick self that you might be, used to addressing is a good way to support their health and improvement. And person-centered care is provided over time. As someone, I don't have my lady here, but someone over here said earlier that the effects of not having enough time with someone affects the kind of way that you approach an understanding of who they are, right? So person-centered care takes more time, and it's also accumulated over time, right? You can't really do person-centered care in one 15-minute visit. I mean, I guess you can take a stab at it, but it's accumulated knowledge over time about that person and the whole, their whole life. And person-centered care is ideally accessible, it's comprehensive, it's continuous over time, it coordinates when that person is receiving care in other places. Like we said, it implies a time focus rather than a visit focus. So maybe I'll dig into that one just a little bit. When I say implies a time focus and not a visit focus, who wants to tell me what I mean by that?
Who they are.
Yeah? Right. Yeah?
Overall goals over the length of time, where would you, what are your hopes and dreams over the next 6 months? Or
Right.
over the next year? What are you going to do specifically between now and the next time I see you in the office?
Right, that's right. So it's trying to help people figure out, right, bigger picture goals for their life. What does health mean to them? As we said before, what's most important for them to, what do they want to work on? Where do they feel there are problems or issues that they would like to shift? It's different, right, than responding to someone for whatever they come to you for in one particular visit, right? The sort of older, more traditional healthcare model is that we respond to whatever someone brings to us in that visit, right? They come in, they have the flu, we treat the flu, they go home, right? We don't really think about the bigger picture of prevention or, are they necessarily at risk for something later on? I mean, maybe we do a little bit, but in general, we come from a system that's acute focused and reactive, right? That sort of deals with the people as they come, ooh, there's my mic, deals with the people as they come, visit after visit, and we respond to that, but we don't really think about them before the visit and after the visit. So we're trying to move away from that, right? Care coordination is a way for us to move away from a visit-focused approach to patients. And as we said, a person-centered care relies on knowledge that's accrued over time, and it's not specifically focused on particular disease episodes. So let's talk about health risk assessments. Who wants to tell me what they think a health risk assessment is? Maybe someone in here who is doing a version of one. And this is a broad term, right? It may just be called an assessment in your place. Yeah.
I don't think it is like a screen like the PHQ-9 or whatever for depression that's what I think it is.
Okay, you think of it as a screening, like the PHQ-9. Okay.
Kind of behaviors that may be contributing or catalyzing illness.
Okay, so
Assessing that and screening it.
assessing for, you said lack of support system,
Certain behaviors, choices.
behaviors, okay.
Environmental factors and that kind of stuff.
Mhm.
Yeah.
What else? What other things do you cover in an assessment?
A lot of just basic lifestyle questions.
Okay, lifestyle questions. Want to say a little bit more about that?
That is what type of behavior someone might be engaging in, where do they sleep at night,
Okay. Where do they live? What do they do? Yeah. Say it again.
Support.
Supports, absolutely. Yeah.
I think that's what I was where the patient might need the most help.
Great, great. A tool to help tease out where a patient might need the most help. Very nicely put. Yeah. Yeah.
Oh, sorry.
It's okay.
Well, what we do is we do vital signs, so we go over their medications with them, how they're taking their medications, cognitive, nutrition, fall,
Yep.
risks.
Okay.
Yeah.
So, tell me your name.
Karen.
Karen said vital signs, medications, cognitive score. So what I'm getting at here, and I'm just teaching kind of one approach, but for a care coordinator, in general, the best practice is to have an assessment that is comprehensive. So maybe you work in a social services agency and maybe you only screen for social service needs. Maybe you don't do, I don't know, maybe you don't do a review of clinical issues. Maybe you work in a more clinical setting and you focus less on social service needs. What I'm trying to get at is that we want to really do a full assessment, at least touch on the basic core areas. Yeah. Yeah.
Someone could go to and find.
Yeah. In fact, did we put the ARC, I don't know, I don't think you have it in this.
Resource list?
Yeah, there might be stuff in the, I have a source from AHRQ, and they have a basic comprehensive assessment that I think is pretty good. Sometimes I've included in the packet. I don't know if it's in this packet, and it may be in your resource list. If not, at lunchtime, I'll get you the link for it. Okay. We have it back home. We just.
So, with the person-based, back up, but.
Yeah.
So what I see is patients come in for acute.
Yeah.
Because, and it's hard to get people to come in, well, you really need to get your thyroid checked, whatever, because they don't want to take time off from work or they can't do their copay, so.
Yeah.
So I think that's one of the reasons that it's so more geared around their chief complaint as opposed to that person.
Yeah.
I mean, because you can't, in a visit, you can't do like all these.
I do know.
Assessments when they only come in when they're sick because they can't afford to come in anytime else.
Yeah, and just so, just to be clear, I hope it's not seeming like I'm, kind of placing judgment. I'm more sort of trying to surface the system that we all are forced to work in, right? And I'm hoping that someone mentioned earlier, that is, if you're in a care coordinator role, and I know, there's different variations of what that means in this room, that you possibly have more time to spend with a patient. But if you're doing care coordination as part of, being a nurse in a doctor's office and you're just triaging patients through those 15-minute visits, then of course you could not do this to the same extent, right? But I'm hoping that you all have some time to be able to carry this out. Yeah?
With our assessment, we determine what issues that are important to them to address.
Right. So the thing is, an assessment, right? Well, I'm just going to go to my next slide. So an assessment, in a best practice kind of situation is really a systematic approach that is collecting information from individuals, and it's going to help you identify, as this woman said here before, risk factors, and it provides a kind of individualized snapshot of this person, and it helps guide you in terms of making a care plan for them, right? So you can't really do a good care plan without doing a thorough assessment. And that may mean even thinking about what your organization is assessing for, what's missing, what needs to be added, if anything.
I'm wondering if other states get some information from consolidated databases. Here in Vermont, we have different databases, people get different services. They don't talk to each other, so the person is constantly being asked, do you get this, do you get that? So there's a lot of information that can be gleaned from what kind of things the person's already getting support with. Are there other states that have got that down? I'm just curious to know, because we're a system here. pretty antiquated from what I've been told. They
I mean,
don't
I
talk to
think
each
if
other.
tell me if I'm hearing you correctly, but I think you're saying that, like, you might do a full assessment, and then that person goes over somewhere else to another visit or another.
Or some things I could glean from the information in the system. I'm having to ask the person again and again. I mean, waste
Right.
a bunch of time to say, do you get this? Do you get 3 squares? Do you get,
Right.
this or that?
I think that's
No.
mostly right about needing, like, health information exchange, needing better IT. I think most states are still really struggling with that. I mean, in New York, there is an HIE, but it doesn't work with everybody. In New York City, we have 16 different hospitals, most of them on different systems. If you're within a hospital system and those clinics and those mental health places, all those places might be on one system, but the bigger systems don't talk to each other. And believe it or not, even within systems that are electronically connected, we still have silos. You still have places that we just worked with a group like this, that have built separate care management electronic systems. So their care managers are logging in information in one place, and the docs are over here in another place. We even had another system, same organization, mental health's on a totally separate EMR. It's kind of crazy. Let's hope, 10 years from now, it's someone has gotten some sense and some guidance has been given that, people can't just randomly build new systems, multiple new systems, because obviously it doesn't work. Okay, so what I'd like to do now is an exercise. So you'll see around the room that there's newsprint, right? Here, housing, mental health in the back. So let's see. I'm going to have you count off, and then whatever group. Like if you're like, I'm going to have you count off 1 to 6, 7. How many things do I have? 1. Sorry. So we're going to count off 1 to 7. So the 1s will go here first to this place. The 2s here. The 3s, the 4s, the 5s, the 6s, the 7s. And then I'm going to tell you what to do. So let's count off here. You start.
1, 2, 4, 5, 6.
So here's what you're going to do. Once you get to your spot. In front of you, you have what I would call a domain, or hi, listen up, I'm giving instructions here. So in front of you, you have a domain or an area of assessment, right? And what I'd like you to do is work with your team. You're not going to spend too long there, and write down what you think are kind of the core questions or areas or things you might assess in each of these things. So in mental health, right, you might say you want to, first of all, know any diagnoses the person has currently or in the past. Okay? So you're going to list some stuff. You're only going to get about a minute here, and then I'm going to ask you guys to rotate. When you rotate, you're just going to look and see if the team before you forgot anything. Okay? And then we'll rotate a couple times. So go ahead and start writing stuff down. What you want to assess in each of these areas. Okay, everybody. I'm going to have you guys switch. It's okay if you didn't put everything there. Everyone move to your right. Check out what the team did and what you would like to add. So you guys come on over to the right. Sure, you can hold on to your pens. That's fine. Yep, you're going over here to this, on your left here, medical, physical health. Yeah.
Like, who else are there?
Yeah.
Give me correct. Give me correct. So wait. All right. So did you learn anything doing this? Any aha moments, or I'm curious what this was like for you guys. Any things that you hadn't thought of or that other people?
I think it's good having a lot of people with a lot of witnesses to chime in, because everybody's thinking.
Yeah.
They do. So that was really.
Yeah, that's interesting,
Having
right?
people with us every day, what we did, that would be.
Right, right. Hi, everyone. Let's all focus. People in the back too. People in the back. Let's all be together here. So this person said that it was nice to have different team members who weighed in and sort of brought their different perspectives, and nice to have people from other organizations. Other thoughts? Yeah.
It all blends in.
It all blends in.
Yeah.
You want to say more about that?
Yeah, like for example, like especially the social, it's such a broad thing that affects every page we have there. Just put it, like tape it up to the social and vice versa.
Right.
I mean, mental health is going to affect, their physical health is going to affect their social, legal.
Right. Right. So you.
Capacities, everything.
Right, you start to see the interplay, right, really clearly, and the need to assess comprehensively, right? It's like a big, it's like you're a detective, right? And you're trying to pull all the relevant information, and I always feel like you never quite know where the secret or the answer is going to come from. A lot of paper moving here. Hi.
Just like, if you look at it, like, for instance, like, you could have transportation, and probably transportation or financial status is on every single one, so it helps you kind of come up with like the root cause, like
Yes.
what might be the first barrier to get through in order to impact their health better.
Right, so Beth said, because I'm not sure you can hear over there, that, for example, you might be putting transportation on each one, and it helps you kind of get to the root cause of what is going on with this person or patient. And I know some of you, right, are in the Learning Collab, and do any of you do that root cause work through the Vermont Learning Collab? I know that's something they were teaching, trying to get at the root cause of what is causing a person's problem or condition. Yeah. Other things or, yeah.
So time was an issue, so it kind of matches something we have a limited time.
Yeah.
So there was only a couple of things that we all built. If you looked at every single one of them, there were more and more. We just added.
Right, right. Right, so you mean kind of like everyone else, like you do
You
your,
can only do a couple of things at one time.
Right.
And the next time, you can build on to that, and the
Right.
next time, and if you forgot something, oh, shoot.
Right.
Frank mentioned this, add on.
right, so you're sort of building over time a comprehensive understanding of this person. Yeah,
I just keep going back to the importance of a multidisciplinary team.
yes,
We have
yes.
very, very complex patients.
Yes.
Because, all of these domains, as I think Harold said, are, touching on one another, and they influence and impact health status
Right,
in so many different ways. So
Right.
it's all connected, and the importance of, we all look at it with our own lens, as we've talked about, our own lens and our expertise, and how important it is to not work in isolation and think outside of the box. And I'm very thankful for a lot of the team members that I work with that come from different disciplines to help kind of really bring a full picture to a particular patient scenario.
right, right. So the importance of an interdisciplinary team for complex high-risk patients. And the truth is, it's important for all of us, right? But it's probably less important if you're relatively healthy and you have a cold, to assess whatever else is going on in your life. But if you have multiple chronic conditions or face homelessness or housing issues or have mental health conditions or substance use disorder, it's really critical to have an approach that is supported by an interdisciplinary team, different perspectives. And that's also, I guess, what we're getting at here, doing a comprehensive assessment. Even if that's not your particular, strength or focus, you still need to do some basic assessment in all the areas. Yeah.
I think a lot of it is, shared over time. When I'm a patient, I don't go in and want to share all this stuff with people that I don't really even know. So over time,
Right.
we deal with information up to things I consider quite personal.
Right, but as care coordinators, I mean, what we're hoping, right, is that you are the one person, or your team is the one team that's getting this comprehensive understanding, right, of the person, right? That all that information is not in 7 different organizations, right, with 7 different teams. That hopefully there's one place, maybe even one person, it might be you, who over time has a fuller and broader sense of this person.
I think in my practice at any rate, there are multiple, there are interdisciplinary people involved in the complex situation or the complex patients, but it's facilitating communication that is the big challenge.
Between those
So-
different team members, you mean?
Right, so everybody knows what the other person is doing. That, I don't
Right.
see that.
Right, yes, and that's not a challenge that you're alone with, like, that's a challenge certainly in New York and California, you know, all the places we've worked, and we're gonna talk in a minute about shared care planning, and maybe some ways to address that. Okay, so, these are just some of the things I had, but I think you guys did a much better job at, you know, at covering this. So I'm going to keep going on and talk about some best practices. So some best practices for doing a health risk assessment. I don't know what kind of assessment you have. Maybe, you know, maybe you're ahead of the curve and your organization has something that's in plain language. I know we've worked with many organizations that have things like a 17-page form with questions to ask a patient that takes 2 hours to go through. And people end up, you know, doing a lot of box checking, and it's a really not great experience for that patient or client and the person doing that. So I would urge you, if you have anything like that where you feel like you're just trying to check the boxes and get the information, to try to think about how you can translate things into plain language. Remember, we talked about that in our first session, right? Turning it into language that is easy for the person to understand, making it conversational. And you have in your packets, excuse me, some talking points that PCDC actually designed from another project where we worked with a care management organization. And you have their conversational language for each of the areas. So how to do assessment in around physical health, around mental health, and it gives you some guidance, and you're free to use that, incorporate that into your work if that seems helpful. The goal of an assessment is not just to collect information, even though that's what it seems like on the face of it. Your sub-goal is to build a relationship with that person, and it's an opportunity to have a conversation with them and to get a fuller, deeper understanding of who they are. And, you know, I think I say it here, but, you know, assessment done well, you know, is building a trusting relationship. Done poorly, it really may be the last time that you see that person. So let's talk about a shared care plan. The care plan is sort of what we're building to after doing this comprehensive health risk assessment. And, you know, ideally it's created with the patient and with their family and or support people if they want those people involved. And ideally the interdisciplinary team or all the people who are touching that patient or working with the patient also are at the minimum aware of what's in the care plan, and, you know, in a better situation are having an active discussion about the best approach with this person, that's then kind of, you know, worked through with that person as well. A care plan is something that should be updated on a regular basis. Does anyone have guidelines in terms of when a care plan is made, when it must be updated? Does anyone get paid based on doing a care plan here or no? Like in New York, we have a care management program that comes through our Medicaid system, right? If you're on Medicaid and you have 2 chronic conditions or one chronic condition and a mental health condition, or you have HIV, you are eligible for the health home program, right? And those care managers who are paid by the state, you know, through the plans, get paid when they make the care plan, or they have certain tasks, right, that enable the fees to come to those organizations. But it seems like maybe in here, no one's doing it that way. Yeah.
I used to work in dialysis, and Medicare required us to update the care plan monthly.
Okay, so right,
To do a full team meeting, so it's for the nurse,
Right.
the physician.
Right, so anyone have to do a care plan for a payer, for an insurance company? In California, we're working on a project, and that's how it's working there. The insurance companies actually are deciding, when the care plans are updated. Okay, well, you guys live in Vermont. It's super cool here. Yeah.
Well, Vermont Chronic Care Initiative.
Uh-huh.
That's through Vermont. They have care coordinators. They definitely have care plans, and they have to update them every
Okay.
Home Health has care plans as well.
Okay.
But I don't
Okay.
think anybody here is.
Yeah. Okay, thank you.
We have care plans with they're mostly based out of prevention,
Okay.
so that we can help support them where they're at, watch their illness or just make them stronger so that they can.
Okay. Mostly based on prevention and help them from getting sicker. All right, so the only reason I mention this is that best practice, whether you're getting paid or not, is to a care plan is a living document, right? There's no point in making a care plan once, and we want to not think about it as something we make once and forget about. It's a living document that we have to keep coming back to, that we have to keep checking in with the patient or the client about, and that we also have to have conversations with the rest of the interdisciplinary team to make sure that we are coordinating all the different services and that we're all kind of on the same page about the approach to take with a patient. Did you want to say something?
I'm just curious about your experience in terms of how that happens.
Yeah.
At the sort of point of care.
Yeah.
So we have payment requirements in Department of Mental Health or ADAP, the Drug and Alcohol Programs here, require us to update care plans periodically, either annually or every 6 months.
Yeah.
But really, they should be updated as sort of the person changes and their needs change.
Right.
But that doesn't really happen because of the
Right.
complicated system of doing that in our EMR.
Right.
Do you find that people are using their systems, their technological systems, to update those in real time, or they're doing it according to?
No. This is what I've seen, and this is what I would say as best practice. I don't think that, like, a care plan is not a soap note for those nurses and more medically, clinically focused people in here. It's not every visit where you have diabetes, take your meds, stop smoking, see you in 3 weeks. That's not a care plan, right? A care plan is a much more comprehensive thing, and best practice is to do it at the beginning after an assessment. If the person is really super high risk and complex, then maybe it's every 3 months that you're updating. If they're more stable, every 6 months. I don't think it's realistic to say, like, every time we see this person, we're updating the care plan. And after critical events, right? So by critical events, I mean after an unplanned hospitalization, after an ER visit, or after a major change in health status, a new diagnosis, something like that. So I think we have to strike a balance between thinking that we're just updating it all the time and trying to get a process in place where we comprehensively update it. And part of that, I'm getting way ahead of my slides here, but part of that is about having some sort of process to meet with the team and meet with the patient, right? So the truth is you don't update a care plan in a vacuum. You update it after there's been some sort of call or meeting and everyone is discussing what's happening with this person's care and how the person is doing and what their response to that is. Did you want to say something?
A question really,
Yeah.
I'm wondering in your experience if there is a given number of participants that you're working with as that care plan manager in this kind of intensive way.
Right. So we just finished up a collab in New York where we worked with 5 organizations to try to set up processes for that team-based care planning process. So what the teams worked on was having the primary care doctor, a mental health provider, a care coordinator, and then sometimes, someone else who might be involved with that patient's care, or even a front desk person or an admin person, but to have regular case conference meetings where they were discussing clients or patients that had critical events, had new care plans, and so they would have their meeting, kind of figure out what their plan was. The coordinator would update that care plan and then go back to the patient and work through it with the patient to confirm that the patient was on board with that. But the coordinator was that liaison, right?
So, and that's helpful, having you describe that, but I think I was asking how many patients.
Oh, you're talking about caseloads? Yeah, what we have, it really varies. It really varies. We're asked this a lot, and we see a variety of approaches to that. I mean, in New York, you have care coordinators who have 50 patients, who have 75 patients. The caseloads are high, but they are working, sometimes if they have, let's say, an RN who then can take the most high risk of that group, right? Or if it's mental health issue, they have a social worker, and then they have unlicensed staff handling, the less high risk patients. So they're sort of a caseload, right? All patients and clients are not the same in terms of the time and input needed, and patients can move in and out of a high risk or rising risk or stable group. I missed my slide that said something about risk. That said about risk scores. I didn't actually talk about that. All right. So a shared care plan, just to go back, right? It tells the person's story, ideally. It talks about a person's strengths, their goals, their short-term needs, as well as their long-term needs, their personal goals, their clinical goals, and ideally it identifies strategies that you've worked on with that person. And we're going to talk a lot this afternoon about how to actually do that, right? How to get at what this person wants to work on or feels they can work on or feels, is actually in the realm of possible. And it specifies who's responsible for what, and we try to give it a time frame, right? Now, we may not make that time frame. We may say, we're going to do this in the next 3 months, or the patient's going to do this in the next 3 months. And then we come back to it and we didn't make it. So we don't just throw that goal out the window. We reassess, we talk with the patient, we maybe we overreached, maybe something, critical happened that got in the way of this goal getting accomplished, and then we set a new time frame. But we don't just leave it open-ended, right? I've seen care plans that say, whatever, lower A1C, like lower A1C, endlessly. It forever. Yeah.
Is the state of Vermont, investigations from the state of Vermont from the Health Care Innovation Project, have they set forth guidelines? Here's what a typical care plan should look like. Here's who the typical team members are. Here's the platforms you share it on and others you should avoid because, potential for privacy issues. Do we have that?
I don't believe
no
so,
idea.
and I can tell you very clearly that New York does not have that.
Yeah, okay.
California is about to roll out a health homes program, which is a care management program.
working
They
on it.
also
Okay,
do not
that's
have
good.
that.
I just wanted
This is
to-
something that it would be nice if someone said, here's what to use. On the other hand, you can design your best practice care plan template, but no, we don't have. I don't think any state has a clear care plan form that they should be using.
Or an IT platform to share this among people who are in very different
Right.
organizations,
Right.
including the patient having access to.
Right, and there is, in New York, we have some organizations, a hospital organization that built a website so that you could, it's like a, what do you call that? It's like people can upload the care plan on a portal, yeah, but not just for the patients, right? Also for the providers, so they can log on there. But it's outside their EMR, right? Like it sits on top of their EMR. And it's promising, right? It's a promising solution because our EMRs are never really going to just talk to each other, right? They're different systems made by different organizations. But there are websites that could sit on top of it that people can connect to.
Do you know of some offhand that do that already?
I know, these are systems that like a hospital system built themselves. Yeah. Okay, so, and the last piece here is that care plans use SMART goals, but I'm not going to tell you about that. You probably know some about that, but Yael is going to take you through that in just a little bit, what SMART goals are. So I have just a picture here of part of, some of you here, I believe, use, this is from a shared care plan from Burlington, the Burlington Shared Care Plan, I got this from the Department of Vermont Health, DEVA, is that what you guys call them? Your Department of Health here, just to show you an example of, goals, steps needed to achieve the goal, who's responsible, when is it completed by. And just want to kind of talk you through the care planning process. So I would urge you to think about a care plan not as a piece of paper or a template that you fill out in an EMR, and to start thinking about care planning as a process and thinking about what are the steps in that process and how does that play out in my organization and in my role and perhaps across organizations, right? Because you're working, I'm assuming, with people outside of your actual physical organization. So just to review, right? We first perform a comprehensive assessment. That's the first piece of the care planning process. Then we try to come to some sort of integrated understanding of that individual. Then we want to try to prioritize the areas that need to be addressed, again, in collaboration with that person. We want to think about goals in each of those areas. And we also want to think about a vision for the future. So just briefly, what do I mean by, and why do we want a vision for the future? That's okay, yeah. Right. Right. So I think in medicine and healthcare, we're good at acute situations, short-term stuff. We're really pretty good at that. But we're not as good at, or we feel maybe a little sheepish about, the sort of visioning for the future. Like in the big picture, what would make this person's life better? What could they do? What could change that they would feel happier, more fulfilled? Right? We don't normally really let ourselves go there, but I do think that is what we're going for, right? Whether it's that they have less pain or they're emotionally, feeling better or whatever it is. So a vision for the future is a kind of, big picture thing for them to hope for, wish for, that all the, as you said, the smaller goals line up to. The goals are realistic, right?
But the future goal.
Let's hope the vision for the future is reachable. If you don't, I don't know, if you're paralyzed from the waist down, you're probably not going to walk, but maybe you're going to be able to hold a job and care for, hang out with your grandkids or whatever it is. I think it's a vision, but it's achievable. But right, we want to talk about and list this in our care plan. What are this person's strengths? What does the person think are their strengths? Right? Ask them, right? And if they're not sure, you might, supply some ideas from what you've observed working with that person. Create objectives or action items that help overcome any barriers that you might have identified. Yeah. Oh, sorry.
I'm surprised with your list.
Yeah.
Because care plans are person-centered generally.
Yeah.
And I'm a social worker, so self-determination is always that. You don't mention that the goals set and the vision, that has to be their goals.
Yes.
What they want.
Yeah, I'm trying to say that. I think it's about what the person wants. It's not about what we want. Most,
right.
If I haven't made that clear, I'll say that again. It's what the person wants. It's not about our agenda. We try to keep our agenda out of it. I'm simply here trying to give you a way of thinking about the process, a sort of, step-by-step way of thinking about, well, how do I get to my care plan, Because I don't think everyone thinks about it in a kind of orderly way, right? And we may not necessarily even have the infrastructure set up in our organization to do that. Did you want to say something?
Yeah, I guess in terms of thinking about the client goal, those goals have to be within the scope of work that we do, right? It can't be something that's so far distant from where we are. And I also think it's clear that we talk, or I think it's important to talk about that it has to be sort of ethical within what we do too. Right? I work frequently with folks who are attached to the Department of Corrections. And their desire in one way or another is often to have the Department of Corrections uninvolved in their life. And so we have to balance what their goal may be with the reality of their terms of release. And so I just think that's always a juggling act to some extent. It's client-centered,
Yeah.
but it's client-centered given the scope of our work, given the bounds which we have to work in ethically and legally. So.
Right, so maybe that's like what we were just talking about, like, you know, that the vision for the future is that the Department of Corrections is no longer involved in my life. I mean, if that could theoretically happen, even if it's 10 or 20 years from now, then that's the vision, right? And then kind of backing up from there and saying like what things need to happen for that to, you know, what are the more shorter term goals that we can work on together to get there. Yeah.
I think the whole process that you're talking about, through the gathering of information and education and discussion would lead to the person making an educated decision that I don't want to work on my diabetes after we've fully talked about it. So while those goals might be there, they're coming with lots of information from this to be able to make that goal. Or I do want to work on it. You know what I mean?
Right.
So it's not like in a vacuum, what do I want? It encompasses all this process before you get
Yes. Right, and I think I'm understanding you. And it is the patient's choice ultimately, right, to even say, like, I don't really care about my diabetes. I mean, you know, it's not necessarily what we think is right, but they are allowed to make that choice.
Assure that they're making that choice with all of the
Correct,
information and
right?
discussion.
You can say, you know, I'm worried, I'm concerned, I'll just leave this for you to read, or if you want to talk, you know, but you also want to be respectful of what this person feels is important to be working on. Okay, so just to kind of tie up just some common care plan challenges that I have seen or we have seen. We mentioned this, you know, care plan created once, never looked at again. You know, before we used to have all the care managers in New York, I think, were on paper. They didn't have EMRs yet. So they would write out these care plans and they would get scanned into the chart because the docs perhaps were on an EMR. And then, you know, where they still are is scanned into those charts. No one ever looked at them ever again, right? Done once, nobody looked at it. Nobody even knows where to find them except maybe the person who scanned that thing in. So that's not what we're going for. I'll give you solutions in 1 second here. You know, common challenges, care plans created without the client or patient's input, which we've just said a million times is not what we want to be doing. Sort of in that soap note vein. I think people, you know, I'm not sure doctors, not necessarily, maybe in Vermont they do. In New York, they get confused. What's the difference between my note and a care plan? Oh, I got to do a care plan also? Well, I don't understand. You know, a care plan is not a soap note. It's a comprehensive plan. It's mostly about coordinating care. It has the patient's goals. It looks at things outside of health. You get it. A care plan created by the care coordinator, and the goals only focus on what the care coordinator is comfortable with. So we had some housing care managers or care managers who were housing specialists primarily in New York, and we looked at some of their care plans, and it would say, like, find housing, you know, find like food pantry. And the patient had all sorts of other things going on, but those goals would that'd be the goals they just put in every time. No bigger picture, because they really didn't feel comfortable talking about anything else, and they didn't have the benefit of a team to talk with. And again, if you're, like you were saying, if you're not in a particular area, you may have trouble formulating goals outside of your area. But the solution there is to try to bring other team members in to meet with, you know, to try to get that process going if that's not happening. Right? What does the nurse think the clinical goals might be? What does the doctor think? If you're not in mental health, what does the social worker think? Creating something collaboratively after a case conferencing type meeting. And then lastly, right, care plans are supposed to be shared with the rest of the team. So the model, again, that we're seeing in New York working the best is the care coordinator as a sort of liaison, like liaisoning between the different providers and updating that care plan, taking information, as opposed to like the doctor's writing in it now, mental health's writing in it now, the specialist is writing in it. That can be pretty challenging. So I think I I think I mentioned my solutions, and you have them in your slides, and I'm going to keep going just to keep us on time, but happy to talk more about care plans at lunchtime or later if anyone wants to.